Hi, good morning. Welcome to Scrubs and Stethoscopes. I'm your host, Kathryn Watson, and as always, with my incredible co-host, Ashley. We are going to be going into some things that I know that are difficult to handle in nursing is effective communication. It's establishing the trust with your patients and other coworkers, handling difficult conversations that you may have, in dealing with aggressive or angry patients or family members, and then communicating with the non-communicable because using your hands is a big thing. So how do we learn to express and have these experiences? So can you discuss any strategies for building trust with patients or their family members in like an initial meeting as we walk into the room?
So yeah, I think that goes back to something we previously discussed is walking in the room with confidence, knowing your patient a bit already. So you're not walking in and being like, oh, what's your name? Like, what are you here with? You want to walk in knowing what you're doing because that instills confidence in the patient and the family. And then that's going to be your foundation for developing that relationship. If they're not confident in you, they don't want to hear what you say. So
Right.
I think walking through that door with that level of confidence is very important. And then, seeing where they're at. Are they feeling hopeful in this moment? Are they feeling really scared? And just allowing them to feel how they feel. Maybe they're really scared and they're angry at you because they're really scared, even though they've just met you. And just
Yeah.
don't take that personal because then it's going to become a power struggle. So, I think just meeting them where they're at is really important.
Yes, definitely. I found that a lot of patients seem angry, and I think it's because of the lack of control. A
Yeah.
lot of people want control of something, especially when they're getting really bad information about their health or even a family member. We
Yeah.
have family members who are like, they were fine last week. Why is this happening? So, like, the initial meeting with the patient is you introducing yourself, saying
Mhm.
hi, like you said, with confidence. I'm going to be your nurse today. How are you feeling and all this stuff. And then starting the rapport off. So handling the difficult conversations is just listening. One of the biggest things I can say is just to listen. A lot of people just want to ramble on and tell you stories. Like you'll hear lots and lots of stories
Yeah.
about someone's life that you don't really want to hear, but you have to sit and listen because
Yeah.
eventually you're going to hear little points in the conversation that then you can kind of build the rapport with. That's the initial meeting. And like you just said, meeting where the person's at. A lot of things I find is if you get below them, because when you come in and a person's lying down, you're above them. So
Yeah.
just having that up here and you coming down a little bit makes a whole difference in the conversation and how it's going to go, especially when a doctor walks in the room and starts saying something to the patient. And then you have to be the one to kind of be that buffer. Or the patient or the family member is like, I'm upset and I want to speak to the doctor right now.
Yeah.
And you have to be that buffer in between to say, I understand, da da da, try not to be not say wishy-washy, but just be like direct to say, I understand you're upset, use the I statements, I
Yeah.
see, and then repeat back what they say to you. So what approaches do you recommend handling these conversations like with family members, such as delivering bad news or discussing sensitive health issues with them?
So I think that can be really challenging, especially for a new nurse. It's something that you develop over time, but it's balancing that fine line between being kind of blunt and direct and being empathetic because this is another situation where you can't be wishy-washy,
Yep.
but you don't want to just walk in the room and be like, hey, so I found out you had cancer today. Um, but seeing where they're at with it, chances are they already know because as a nurse, we're typically not the one to give someone results. So they probably already had the result. And we're going in after the doctor has already explained all this. And they either didn't understand what the doctor said or they're finally able to process it. And now they have all these questions. So
Yes.
I think it's sitting there and doing your best to answer. And if you don't know the answer, having the confidence to say, you know what, I don't know that, but that's a really great question. Let me find out and get back to you.
Yes, definitely. I always say that too. for new nurses, or even when you're in nursing school and going into clinicals.
Mhm.
And I always try to sit there and tell the students to answer the call lights.
Yeah.
Answer the call lights. That's how you start. Like, I start them with the basics on the first day of clinical and just walking in and having a conversation. And
Mhm.
then the big task of taking a manual blood pressure. It's amazing that we do these steps every single day, and then we have to stop back and not realize that the novice nurse or the student out there has no idea. A
Yeah.
lot of people coming into the nursing field, some of it's a second career. I
Yeah.
was just talking about, like, what age coming into nursing, like, a lot of people like, is 30 too old? And I was saying the other day, I graduated a 58-year-old female who went back to school, a second career, because she
Yeah.
always wanted to do it. So
Yeah.
coming in and just answering the questions, but it's okay to say, I don't know, but I will find out. And if you say you're going to come back, once you say that, you need to come back with that information,
Yeah.
or you need to come back with the person who has the information. And it's okay, as we said in the last podcast, of speaking up.
Yeah.
Saying you don't know something doesn't make it you look stupid or whatever, because you act like going around and, like we just said, the wishy-washy and making you sound like you know what you're talking about when you really don't.
Yeah.
That is not building the trust. It's
Yeah.
building that trust with someone. And then handling the different difficult conversations, as we just said. It's all in the approach of how you do it. And like I said, getting down to the level. So if there's a chair in the room, sitting in the chair, I sometimes kneel down
Yeah.
and I sit there and have a conversation. This is when the therapeutic touch, you ask first,
Yeah.
you say it's okay. And like, the holding a hand goes a long way, especially when you have the elderly patient who really doesn't have that contact. You'll be amazed of, they have all this family, these families come and they go and all this stuff. But when you're sitting there alone with them, you can just see it in their eyes how scared they are, and they just don't know.
Yeah.
So just taking that moment goes a long, long way. So moving into like aggression and anger. So have you ever encountered an aggression or angry patient or even family member?
Yes. So a specific instance comes to mind, although I think we've all had several, maybe not to this degree, but I actually had such an aggressive patient that by the end of my shift, he strangled me. At that point, I had been a nurse for, I think, 8 years, 7 or 8 years. And I was pretty confident in de-escalating behavior. And I feel like it was a skill I was pretty good at before nursing school, because I actually worked with the mental health population. So I had a lot of experience with that. And there was just no de-escalating this man. He was so angry for no reason. He was angry at us. He was angry at his family. It was probably angry at himself too, but not willing to admit that. And it turned into something it didn't need to be, where he physically assaulted me, and the police had to come. But aside from that, I think that, when it's maybe not on that level, getting down at the person, keeping a safe distance just in case, because I thought I was keeping a safe different distance and he still got my neck. But keeping a distance, making sure your exit to the room isn't blocked, and just trying to figure out, why are they angry? And again, not taking it personally, because there is a 99% chance that they are not angry at you. They are angry at the situation. And so I
Yes.
think if we don't take it personally, we can better cope with that. When we take it personally, we change how we communicate. So if
Yes.
you can take that step back and be like, why is this person angry and how can I help? So saying something like, I see that you're really frustrated right now. I'm so sorry about that. Is there anything I can do to help? I want to help you. And putting
Right.
it back on them, like, what can I do for you that would make this better? They
Right.
might say nothing, but they're going to start to think like, oh, that person cares about me. They're asking, like, maybe I can trust them. And it's going to take time. It might take your entire shift, but that's going to matter to them. My next shift after I was strangled, I was very nervous to come to work. It was only 2 days later. And I walked in the hospital nervous about what my assignment was going to be. One of the individuals on my assignment was a man right around the same age as the person who strangled me. He was at the end of the hallway, so there weren't going to be very many people around when I was going in the room. And I was nervous about it. And he was a little aggressive. And I remember every time I went in his room, I was nervous. And by the end of the shift, and he was not a super happy man, but by the end of the shift, we had developed enough rapport. And he said to me at the end of the shift, "You are just such an amazing nurse, and I can tell how much you care. And I'm so glad you're my nurse." And I was like, oh my God, I'm so glad I can't. Like, I was so scared to come to work that day, but I was so glad I did. It put it into perspective. Like, there is a reason we do this. And because of my ability to respect that patient as a human being, we developed a great rapport. And he actually made me feel more comfortable with him and other patients because of what he said to me.
Yes. Yep.
So
Very, very true. It's amazing. I feel the good does outweigh the bad in a normal situation. Everybody is just so very grateful. And a lot of things you hear is, I don't know how you do it. I don't know how you have the patience, especially when we talk about aggressive or angry patients and not taking it personal, is a patient who has a mental illness or dementia, some cognitive, because I can remember in a shift, I had this old guy who was like, "You're stupid, you're dumb, you're a bitch," kind of thing. And all those bad words that you can think of. And at the end, I was like, am I? Am I? And yes, you start taking things so personal. And that is the biggest advice I'm gonna give, well, we're gonna give, is saying, don't take anything personal. Like at the job, a person's in a certain situation, they're under stress. And I don't know if this is where I try to have a concept that I'm working on, is the 48-hour concept of any situation that you're in, it's taking 48 hours to sit and process before you react, but also 48 hours of just sitting with it and processing through whatever emotions that come up with it. So with that said, is that you have to understand to say, where's this person coming from? And seeing what situations, because we don't know and we can't assume. That's the hardest things that I find as human beings anyways, that we just assume things because in our own personal lives and what we're dealing with, we don't see sometimes beyond ourselves. And that is why I go into perception and perspective of the situation, and the empathy of being able to step out and step into the shoes of someone else and just trying to have a little understanding, like you say, the empathy for them of where they are, because each situation is very, very different. So yes, taking that moment for yourself, especially after it, and then coming back into it and just coming from a different point of view. I agree with knowing where your exits are. Don't have your back to someone, especially in the beginning. If you get that feeling, we start developing this nursing intuition, I call it, about something's wrong in this situation medically, and a patient usually has like a change of condition. But this also goes for mentally, because you can have a person who's totally normal one moment, and then the next moment they're off the wall, and you're like, what happened from what just happened? And you don't know if they just got off the phone with someone. You don't know if they just got the bad information and they're just taking it out on you. So yes, don't take anything up like personal. Just step back and ask the questions of like, what can I do to help you? I see you're angry. Why are we upset? And then just let them talk. That's the biggest thing, is don't use the pause method. Pause and let them say whatever they have to say. And then you come back with whatever you need to say. And we can't speak because there's so many different situations, but I hope those little like points help. One of the biggest thing is going in is the non-communication of talking with your hands. I'm a big person. I don't know, I must be half Italian in there because I knock things over. But the biggest things is the eye contact with some people. You know, communicating with your patients, whether it's due to medical conditions, emotional stress, culture differences. Sometimes some people don't make eye contact. You'll realize in certain cultures, like some men do not respect women. So you go in and you give your information, and they're just going to keep beating something back to you, and you just need to realize of where they're coming from. So then, like, can you share some insights or strategies effectively engaging with these patients? Like, what should I do with my hands?
I think that just one, be aware of your hands. Be aware of the way you're presenting your body. Are you closed off? Are you, when you have your arms like this over your chest, you don't feel open. You don't feel warm and welcoming. So being aware of your body language in general, I think, I don't know, maybe it's just us, but I feel like a lot of nurses tend to like talk with parents like, oh, what's going on today? How can I help? I feel like I totally do that too. And I don't even know it.
I wouldn't even realize it. Yep.
Um, I think that's also about reading the room. When you
Yeah.
walk in and you have a patient that's comfort measures only and the family is all very sorrow, you're not going to walk in and be like, hi, Ashley. You're going to walk in and be like, hi, my name's Ashley. I'm going to be taking care of so-and-so today. Is there anything I can get you? And I think if you naturally move your hands around, if you're going to say all of a sudden, like, I'm not going to do that and I'm going to keep them at my side, you're going to look fake. So
Yeah.
kind of embracing who you already are to an extent, but maybe like checking it a little bit.
Yeah. My biggest thing I always tell everybody is this.
Yeah.
Put your hands like this and put them in front of you.
Yeah.
Or sometimes I just put them behind me. Or if
Yeah.
you have pockets, put your hands in your pockets,
Yeah.
kind of thing.
Yeah.
Because you don't realize it. And like I just said, the eye contact and your facial expressions.
Yeah. Yeah.
People don't realize when someone's saying something, you have to sit there and just kind of concentrate on your breathing and breathe through whatever the person is saying. Because
Yes.
like I said, you'll get some wild stories,
Yeah.
especially too if you're doing something. If you're bending over and you're like, let's just say you're flushing an IV. Or you're doing something to the person, they're going to be staring at you, especially when you're doing a blood pressure and you're like watching it and they're watching you. And if it's off or something's happening, you got to remember your facial expressions.
Yeah.
Because that's a biggest thing. Like all of a sudden you're like, what's wrong? I saw your face,
Yeah.
and you don't even think about it. So that's why every time you walk in the room, you just have to remember to kind of check yourself.
Yeah.
And just say where I am and then go in and do something and tell them what you're going to be doing and then do it, but then try to relax your face as best you can. Because that's my biggest giveaway too, is I'm like, oh, yeah. And they're like, hello, I'm over here. And you're like, oh, I know. I was just looking like, or you can use certain things. Like if someone keeps talking about something, you can use the room to say, have you noticed the tree outside? I like that color. Or walking into a room and you want to know. And I have walked into rooms where family and everybody's kind of talking and having a good time. And I said, hey, knock on the door and saying, hey, sounds like we're having a party in here.
Yeah.
I'm coming in to do XYZ. So that's about reading the room and I'm here and being that nurse and enjoying the conversation they may be having. But yeah, definitely you always know when you walk in a room what's going on. But definitely reading the room and then having that compassion demeanor for them. And like I said, ask to say if it's okay to have a seat. This is where I try to, when I was talking about time management, you go and you do your rounds, you give your meds, you flush your IV, you did everything. And that's when every hour, as you're supposed to, you go around. And if it's 5 minutes, or you need to know that when you read the room, saying this person in this room, I can go in there very quickly.
Yeah.
This person in this room is going to need my time. So it's balancing that comes in the time management about what room and saying, I'm going to go into that room last because I know it's going to be 5 minutes. Check in, thumbs up. You're doing good today. Feeling good. No complaints. You check the IV. So if the IV fluids are running every 2 hours, you're checking it. So you're looking, nothing's bad, thumbs up. And then you move on to the next one because part of your hourly rounding, we need to make sure everybody's safe. Make sure their bed alarms are on, everything's running okay, and then going into the last person who may need that little extra time. And usually it's the toiling with the old elderly people who need the time to get up out of bed to go do something. But that's when you're going to be communicating with them about what's going on. Yeah.
On another level too, non-communicative language, you also have patients that can't communicate. You might have a severely mentally disabled patient who cannot talk, who to us might be able to not make their needs known. So typically they have a caretaker or someone that's involved with them. And maybe that means picking up the phone and saying, hey, I'm taking care of so-and-so today. Can you tell me how this person would normally present if they had pain? Because we usually are talking to patients saying, are you having any pain today? What's going on? And So you have to pay attention to all those nonverbal cues from your patient as well, especially when they truly can't communicate with us in any other way. So that's something that I learned early on before I was a nurse because of what I had done previously. I remember being in a training with that company and being told, when you are taking care of a client, you should be thinking, if this was my mother, my father, my sister, my brother, how would you want them to be treated? And if
Yeah.
you're not treating them that way, you should go find a new job. And
Yes,
so,
definitely.
so when you're taking care of a patient, you need to do it with pride, and you need to do it in the way that you want your family to be taken care of. And remembering that sometimes it is that touch or the way that you're just performing your care that is showing how much you care about the patient. So I had a patient who was nonverbal. The group home was in there the whole time. And every time I went in to perform care on him, I spoke to him. And I remember the group home person saying, he can't talk back to you. Why do you keep talking to him? Because for all I know, he understands what I'm saying. And I want to give him the respect of knowing what I'm doing to his body because he's a person. And I can't imagine walking into a room and just doing X, Y, and Z and not saying anything. So
Yes, I try to teach that in school, even because one of the big topics we have is end of life.
yeah.
And I always say that hearing, everybody can hear. They may not be able to speak, but they can hear and they can feel. And you have the spidey senses that we talk about. And you just know someone's looking at me. I can feel someone's in the room with me. Just
Yeah.
even if in public or whatever, and you turn your head and you make eye contact with someone. So yes, definitely. I always say talk to everybody,
Yeah.
even if they can't hear you or communicate, talk. And I always say, like, hello, use their name. Always ask what a person wants to be called. Part of our admission stuff is we ask, what name do you prefer? Because in today's day and age, we don't know what people prefer. So the respectful thing to do is just ask. And that goes such a long way when people are like, thank you. I can't believe, thank you for asking. I very much appreciate that. And that's the start of just introducing yourself and asking simple questions and building that trust and that rapport. I want to say that if anybody has any comments or any experiences that you had, leave them in the comments. Give this I can't even talk. Give this podcast a thumbs up or a thumbs down if you don't like it. We're here to help. We're here. We want everybody to kind of engage, and we want to know how you would handle different situations. What are some non-verbal language, body language that you use? Because like you said, with the arms crossed, I find that to be such a natural position that we all kind of go into. But like I said, just being acknowledging of how you are. And that's not just at work. I try to tell everybody that things take time. It takes about 63 days to get a certain habit and a pattern. So just practicing in your daily life and realizing it. Because when I was going to school as a nurse, got out, and then going for my master's in teaching, and then me trying to decide what I want to do. Am I a leader? Am I going to be a manager? Like different career paths. And a lot of people are like, you're very tactless. You're not tactful and how. And I was like, what? Wait, what? And I was so offended by it in the beginning. I was like, me? No, I'm the nicest person. And I never realized it's because I felt so overwhelmed with the job and trying to get everything done within my time frame that I had and I set out for myself, that if a call light goes off and you go into the room and you're like, yeah, what do you want kind of thing. And you don't even realize, or picking up the call light, you have to realize how you're speaking to people. Your words mean a lot. And if you don't realize that you're doing something, or if you're in the same situation and people around you, when you ask for feedback, because always ask for the feedback. It's hard to hear sometimes, but I'm telling you, you're going to learn so much from it. Because I was like, I'm tactless. I'm like, wait, what? And then I realized it was because I was in the middle of something, in the middle of a thought process. So if I did react to someone, I would apologize. I'm sorry, I didn't mean it. I'm just you have my full attention now kind of thing. And just let other people know, because it's we're not mind readers. and we don't know what other people are thinking. So it's just like you said, checking yourself to make sure that you know where you are and then how you're expressing it to the world.
Mm-hmm.
So reflecting on our experiences, is there any instances like in your own personal life that like you can say for nursing, like you used in nursing and then it kind of went into your personal life, that you had the similar situation that you kind of learned from?
I would say, as we talked about last week, I went through IVF. It's incredibly hard, but I do think that going through IVF made me a better nurse because it is so emotionally and physically challenging that when it was all finished and I went back into working as a nurse after I had my son, I had a different outlook. I could, you always try to empathize, but I felt like I could do so better because when a patient got angry at me, I would remember, oh, I got really angry at my nurse because I felt like she wasn't listening to me and I was so scared. And when I look at it, I'm like, I wasn't actually angry at her. I was angry at the situation. I was scared and I took it out on her and she handled it with grace. And so should I.
Yes, that's
So
a
I
great,
think
yes.
turning it back around, and maybe you don't have an experience where you can really look at yourself in their shoes, but try as best you can, especially I remember working on a holiday and I was taking care of this patient and everyone's like, oh, he's so grumpy today. And I'm like, well, it's Thanksgiving and he doesn't want to be here.
Yeah.
And I went in and I said hello to him and I was like, I'm so sorry you're here on Thanksgiving, but I'm happy we get to spend it together. And it completely changed how he communicated with me for the shift. And we had a great shift together. He was not the grumpy man everyone said he was. So
Yes, I don't know if you found this, like you get report from someone and sometimes instead of talking about why they're there like medically, they talk about the personal stuff and they sit there and they'll say, oh, he's a grump or she's this or she's that or whatever, or watch out for that family member.
yeah,
And I have found over the years, it's everybody's personal perspective of a situation that I'm like, okay, and I take it in consideration, but I don't really go with it because guess
yeah,
what? I haven't had an experience with someone. Once I have the experience with someone, yeah, I can pass it along and they'll keep it like, just be careful because of XYZ. Like, let's just say giving medications. They like it, they do one at a time or
yeah.
whatever to prepare. And that's good information to pass
Mhm.
along. But if you turn around and then you're just saying they're a grump, they're this or that, it puts a bad taste in someone's mouth and they're
Yeah,
going to approach the situation different. So I've learned that when nurses that are giving reports start talking about any of that stuff, I'm just like, okay, thank you for letting me know. I'm going to walk in the room with that in the back of my head just a little bit to prepare
yeah,
myself, but I'm not going to sit there and use it against the person because I haven't experienced, like you said, they're there on Thanksgiving. Like
mhm,
people don't realize that. And we're so used to the environment and working 7 days a week that we don't even think of. Because if I was talking to someone, they're like, oh, I'm working for the weekend, and then after I was just like, working for the weekend. I was like, I never thought about it like the 9 to 5 until all of a sudden I had to step out of it and think about it, going, oh yeah, the days off they have is weekends where we work weekends and like it's nothing to us. But the normal people who work Monday through Friday, 9 to 5, the weekends are their time or
yeah,
holidays off with their family or they have plans, and that's all messed up because our body doesn't want to work with us. So
mhm,
I always make a joke to say like, hey, you're just like a car, you only got the one car, you got to take care of it. So I go, your body just needs that little tune up today and we'll get you right back out there, kind of thing.
exactly.
Yes.
And at the end of that holiday, we're going home. Like
Yes.
we're staying in the hospital. So I worked through to 11. I remember I had a turkey dinner at my mom's house down the street from the hospital, went into the hospital and I took care of him. And, yes, it wasn't ideal that I had to work on Thanksgiving, but I still had some time with my family and he got none. Like, yeah, his family came in for maybe an hour to see him, but he didn't get to sit around the table and have a meal with his whole family like everyone else.
Yeah.
So,
That's one of the hardest things I find is, or sad the most,
yeah,
is like you have the holidays and nobody comes.
yeah.
Like I always try, if I'm working the holidays, to spend that extra few minutes with someone, especially like saying Thanksgiving and you have the Macy's Day Parade. So I'll
Yeah.
walk in the room and say, what are you watching? If they're watching it, I'll sit there and watch whatever they're watching. Because the thing is too, I find joy in that, to say that I'm getting paid in a job to sit here and kind of watch TV with someone,
Yeah.
but you're actually doing something. And
Yeah,
especially too,
very
like if someone needs to be a feed and you have to feed them, like a lot of people don't realize the things that we do. And like I'll go tell everybody like, hey, I'm gonna be in room 3 because I have to feed Joe, kind of thing. And
yeah,
you go in there and just spending that little time and feeding them and then not rushing makes all the difference. It's always like we always seem like you're in a rush. So
yeah,
it's just taking that time. And this comes down to the time management and prioritization of what you need to go do, and setting it up, like I said, that if you know that person is going to be difficult in some way with conversation or tasks that you have to do, make them last in your priorities so you can spend that extra time and you don't feel rushed. And this is where I say the flow sheet that I made up for everybody to go by, to say, what are the tasks that you need to do? And then check them off, kind of thing.
yeah,
And then going back to the communication, it's communicating that you're going to tell someone, because they have expectations. The doctor said, I'm going to get XYZ or whatever they say. Let's just say a dressing change, that you
yeah,
need to tell them to say, hey, I have someone else here. I'm going to go handle blah, 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 or meds I have to do. I will come back to you. And you
yeah,
need to go back to them. So if you communicate something with someone, you have to follow through with whatever you say you're going to do. My biggest thing that I found, or I started to doing, is the end of the shift, like rounds. Like I work days 7 to 3, and at 2 o'clock, when you have 2 o'clock meds, I would make that in the last round. And if someone doesn't have 2 o'clock meds, I still go in their room, because as we went before, is that checking your patients and documenting that. I've had patients, or I read that the nurse said they were sleeping soundly, and sadly the patient was dead.
yeah,
And that is why I could never go home. The one big experience I had is I had a patient who had abdominal surgery, and I checked the dressing and everything was fine with it. And I was like, okay, good. Did the dressing, no issues. So then my 2 o'clock round, I went around and did all my rounds. And then I went in and I'm like, I'm going to check the dressing, because I could never go home. I would be worrying about
yeah,
everything. Did I do this? Did I do that? Did I don't know. And then part of my practice, I changed it, because I did the 2 o'clock. I walked in the room, checked the dressing. I know there was like a little staining on it from before. And at the end of my shift, I would always mark out dressing. So then when I give report to the next nurse to say, hey, I noticed a little staining, I marked it out for you to see. So since that happened, I happened to lift up the dressing just to see, and he dehissed. And he had to emergently go back into the OR, turned into this whole big thing. So from there, I always tell everybody, is to make sure that you do your checks at the end, and then communicate that to the next nurse to say, I noticed XYZ. I like the dressing, I marked it, or whatever. Or if you have a NG tube in the section, and then clearing your pumps and stuff, so then you can communicate that to the next shift, kind of thing. So I
mhm,
know this was about communicating with patients and building trust, but this also falls into communicating with your coworkers or the next nurse coming on, or even if like difficult conversation. One of the biggest things is going to the charge nurse, because a lot of patients don't want to hear what you have to say. So it's communicating with the charge nurse. And if
yeah,
any of these situations happen, my biggest thing is you need to document that. You need to sit there and document that this is what happened, this was what was said, and use quotations for whatever the words the patient or family member uses. Because
mhm,
I know at the end, if they want to sue, that's going to come back. And it's
yeah,
either going to make you or break you, kind of thing. Because when I read charts and I look at it and saying, this nurse wrote all this down, okay, this is the scenario, what happened. And then the next nurse did or didn't do that. So then I'm going to go to the next nurse and say, hey, I noticed XYZ, the prior shift had this, where are you, kind of thing.
yeah. That makes
Yeah.
sense.
Yeah. So anyway, so I want to say thank you to everybody to listening to us this morning. As I said, if you have any comments or anything, leave them in the comment box below. Follow the links if you're interested to go to educationalnurse.com. And we appreciate you listening. And thank you, Ashley.
Thank you.
All right. Have a good day.
You
Bye.
too. Bye.